Good evening and welcome to tonight's CPD webinar, Hepatology Update. My name is Phoebe. I'm the Sexual Health and Viral Hepatitis Program Officer at Central and Eastern Sydney PHN. Joining me tonight is my colleague Christina from the CES PHN events team. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay my respects to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. Please note that this webinar will be recorded and will be available on SESLHD's YouTube channel within the next couple of days. Please submit any questions via the Q&A box, and to view the Q&A, hover over the toolbar at the bottom of your screen. At the end of this webinar, an evaluation survey will pop up on your screens. Please complete this to allow us to issue certificates of attendance. We would like to continue delivering CPD events around liver health, so please let us know if there are any particular topics that you're interested in learning more about. And a copy of the slides will be included in the post-event email if you'd like to get further information on anything. I'd like to introduce our facilitator for tonight, Dr. Nada Andrick. Nada is a GP at the Reverend Bill Cruz Foundation in Ashfield. Thanks, Nada.
Thanks so much, Phoebe, and welcome everyone, and thanks for joining us on a Tuesday night. I'm here on Ngunnawal land in Canberra, and I'd love to introduce our three legend speakers today. We've got Dr. Hester Wilson, who's from the Ministry of Health and a GP and addiction specialist. We've got Dr. Jason Behary, who is a staff specialist gastroenterologist, hepatologist at St George Public Hospital, but also has an appointment at South Sydney Gastroenterology. And he has special interests in general gastro, liver disease, gastroscopy and colonoscopy. And finally, but not least, Nathan McGarry, who is a staff specialist, a CNC at the liver clinic at St George Hospital. We've got really great content tonight, so quite a bit to go. So I'm hoping that we can go through the talks and the case studies quite promptly, leaving us for about 15 minutes of questions toward the end. Obviously, if there's anything burning, type it in during the talks and we can sort of answer them as we go, but it'd be great if we can have a bit of a general discussion at the end. Without further ado, I'd like to start off by asking Dr. Behary to start the talk. Thanks so much.
Thank you so much for the introduction, and thank you so much for everyone online attending on a Tuesday night after a busy clinical day, I'm sure, for most of us. Learning about liver disease, advanced liver disease, I guess, and liver cancer and complications of this condition, which it's become very, very topical, close to our hearts, and I hope that in tonight's presentation, you get a lot out of it. It'll be very case-based, the presentation, so we invite questions and we'll try to answer as many of those towards the end. So try to go. Okay, let's go back to the objectives. So really what we want to do today is cover these objectives. There's quite a bit to get through. But I just want to talk very briefly about interpreting abnormal liver function tests and how to do that appropriately. Recognise the role that general practice plays in identifying patients with advanced liver disease and liver cirrhosis. We want to talk about recommendations around assessment and management of metabolic associated fatty liver disease in primary care. We also want to talk about identifying and assessing individuals with alcohol-related liver disease in general practice. And also, we will very briefly at the end talk about hepatitis B and hepatitis C testing and monitoring, and talk about hepatoma screening and in what groups that should be implemented and how to identify those patients at risk in primary care. So I'll just start off by talking about abnormal LFTs. Very briefly, I just wanted to make a note that the word liver function test is a misnomer. Liver function tests, as we all know, ALT, AST, GGT, and ALK-Phos, don't actually represent an abnormality in the liver's ability to function. It's actually what we call hepatic synthetic parameters that more accurately describe abnormal liver functioning. So, for example, on this slide, you can see a patient on the left-hand side has very abnormal liver function tests, but actually has preserved hepatic synthetic parameters with a normal bilirubin, normal albumin, and normal INR. Whereas the patient on the right-hand side has normal liver function tests, but very clearly has deranged hepatic synthetic parameters. And in fact, what we're seeing on the right-hand side is probably a patient with more advanced liver disease and more at risk of liver disease complications such as hepatic decompensation and liver cancer. So therefore, what we describe as abnormal liver function test is truly just a marker of liver damage or hepatitis or cholestasis rather than true liver function. So try to focus, when you're looking at liver function tests, try to focus on hepatic synthetic parameters. At least that's what we do when we're assessing patients for the severity of their potential underlying liver disease. It's also important to understand that LFTs are not 100% specific. So you can get caught out with an elevated ALT or AST that's actually produced from skeletal or cardiac origin. It's important to know that ALP can be released from bone and GGT from kidney. So sometimes if you see some abnormalities, just think outside the liver for some of those cases with very mild abnormalities in LFTs. The way we try to describe liver function tests is whether they fit into a specific pattern, a hepatitic pattern with a predominant transaminitis, very high ALT and AST, or whether it's a cholangitic or stasis type pattern, which reflects biliary injury. So they're the typical patients that have a very high ALK-Phos. ALP is the key one for that. And then a mixed pattern where they have elevated liver function tests in both directions. And a way to kind of scientifically do this is to think about the R factor of liver injury, and that this takes us back to medical school a little bit, but still very useful. This is a ratio of ALT over the upper limit of normal for ALT, and then ALP over the upper limit of normal for ALP. So it's very, very straightforward, but it tells you whether the picture that we're seeing is predominantly a hepatocellular picture or a cholestatic picture. And then that helps us with our differentials. So if you're thinking about hepatocellular injury, you're really thinking about underlying causes such as viral hepatitis, autoimmune hepatitis, whereas more cholestatic type pictures typically in the non-jaundice patient can reflect other underlying conditions such as primary sclerosing cholangitis or primary biliary cholangitis as causes, or in the jaundice patient, biliary obstruction. So that's just a kind of a guide to how you might think about it, your initial assessment of a patient with abnormal liver function tests. There are some tricks to it as well, and I just wanted to highlight just a few things just to keep in mind when you're seeing a patient with an abnormality on the LFTs. If you have a very high ALT and AST, there are really 4 primary causes that it can be. So we always think of these 4 up front. So acute viral hepatitis, like acute hepatitis A or B, drug-induced, so think about paracetamol, that's really, really important. Hepatic vein thrombosis is a less common cause, but can do the same. And then ischemic hepatitis, usually that is not something that's seen in primary practice. It tends to be more in hospital care in patients who are unwell with hypertension and concomitant renal injury. But that's just something to be aware of. But I think the first 2 are the key ones, acute viral hepatitis or drug-induced, particularly paracetamol. If you see an ALT that's above 200, it's very rarely metabolic associated steatotic liver disease. Typically, that tends to be more autoimmune hepatitis, and those high ALT levels can fluctuate over time. So important to have a think if the ALT is quite high to consider other causes apart from fatty liver, which tends to be kind of our default, I guess, diagnosis when we can't find anything else. But sometimes we do miss cases of autoimmune hepatitis when it's not kind of evaluated appropriately. There are also other causes, such as obviously when you have an elevated AST to ALT ratio, you should consider alcohol as a cause or Wilson's disease. And then also think about other causes for elevated LFTs outside of the liver, as I mentioned earlier, like skeletal muscle damage in gym goers, for example. I won't talk too much about this, but just to say that if you have a disproportionately elevated alkaline phosphatase, always think about a biliary cause up front. There are autoimmune biliary conditions, PBC, PSC, that are often undiagnosed in the community for many years, and then those patients tend to end up having more advanced liver disease at diagnosis, so have a think about those. And it's really, really interesting that in Wilson's disease, you sometimes see a disproportionately normal ALP or a very low ALP compared to everything else. So in a young patient with a family history of liver disease, if you see a normal or low ALP, think of Wilson's disease as a potential cause. For all of our patients with abnormal liver function tests, we usually do what's called a liver screen, which is quite comprehensive. This is just for information, not expecting everyone to remember this, but have a think about the autoimmune markers that are relevant in the context of abnormal liver function tests. Also think about other conditions that can cause abnormal LFTs, like celiac disease is one of those. And also hemochromatosis is often not considered, so always think about doing some iron studies. And if you have very elevated transferrin saturations, think about doing genetic testing. The key thing that we do, and actually what we do in liver clinic most of the time when we're sitting with the patient, is taking a history, because the history often gives you the answer. It's very common to have patients come in with abnormal LFTs, and you do a liver screen and sometimes even do a liver biopsy, and you don't get the answer for the abnormality that you're seeing. So we don't put all of our hopes in this test, and it really relies on the history that's given to us, and the examination findings help as well. But the key things to think about when you're thinking about referring a patient is patients who have synthetic failure, so low albumin, abnormal INR, or their jaundice. If a patient you think has cirrhosis clinically, biochemically, or in imaging, if the enzymes are very high, always refer them on. Think about acute viral hepatitis and paracetamol. And if their LFTs are persistently deranged and without a clear cause, and you look back at their liver function tests in the past and they've always been elevated, that's probably someone that needs to be investigated thoroughly. I'm going to move on to talking about metabolic associated steatotic liver disease. We're going to talk about a case and then talk around that case. So this is case one. It's a 55-year-old Caucasian gentleman who's a mechanic. He sees you with abnormal liver function tests. He's got a history of reflux disease, hypercholesterolemia on rosuvastatin, reports minimal alcohol intake, and smokes 1 packet of cigarettes per day. These are his liver function tests that you pick up, and you see that he's got an ALT of 67 and a gamma GT of 77. But his hepatic synthetic parameters are reasonable. He's got a bilirubin of 10 and a preserved albumin, which is reassuring. Platelet count is a little bit low, so that kind of makes us think sometimes of more advanced liver disease, particularly in patients who have associated portal hypertension. We think about platelets as being something just to be aware of, but there are obviously lots of causes for a borderline low platelet count like this. On further history, he denies intravenous drug use, tattoos, blood transfusions. There's no family history of liver disease, has not had any episodes of decompensation in the past. He's never had ascites or jaundice or other problems like that. And on examination, he's a typical patient that walks in who's overweight and has an elevated BMI. He has no peripheral stigmata of chronic liver disease, which is reassuring, and it tells us that that patient's less likely to have advanced liver disease, but he does have slight hepatomegaly, consistent with a diagnosis of metabolic associated steatotic liver disease, particularly in the early stages of that condition. I always like to look back at historical results, so don't look at LFTs in isolation. Always look back to see how long this has been there, and when you do that, you see that even back as far as 10 years ago, this patient's had a normal liver function test the whole time, and also has had some borderline low platelets, and that really hasn't changed or deteriorated over that time. And that's very, very useful in telling us what the trajectory of this patient's liver disease is going to be like, and it tells us about potential underlying causes for the LFT abnormality. So what would we do next? We do a liver screen because we want to make sure we're not missing other underlying causes such as viral hepatitis, autoimmune hepatitis, which can present the same, although less likely given the very mild abnormalities we're seeing on the bloods. An abdominal ultrasound is important, and should we consider a fibroscan? We do a liver screen, and as you can see on this screen, there isn't really much to report. The ceruloplasmin is borderline low. Sometimes we see that, and we sometimes like to investigate that further. So this patient went on to have urinary copper excretion tests done, which were normal. But what you can see is an elevated ferritin with normal transferrin saturations, and that's a very common phenomena that we see in patients with metabolic associated steatotic liver disease. And that's just reflective of liver inflammation, pushing up that ferritin. Particularly when the transferrin saturations are normal, it's unlikely that this patient has hemochromatosis, and it's more likely that that ferritin is driven by inflammation from liver fat. We obviously look for clinical risk factors, obesity, insulin resistance, dyslipidemia, hypertension, which tends to go with MAFLD. We want to exclude other causes, remembering that patients tend to underreport how much alcohol they're consuming, and it can be the presentation can be identical. And then we want to demonstrate a degree of hepatic steatosis somehow to confirm that this patient has MAFLD. So that's either via abdominal ultrasound. On FibroScan, we can do a CAP score, and then liver biopsy is another way for diagnosis, but it tends to be, we don't tend to biopsy all patients with MAFLD. Tends to be a more clinical diagnosis that's made. It's also important to know that abdominal ultrasound is not perfect for identifying steatosis, and it's very user dependent. So if you're not seeing liver fat on an ultrasound, it doesn't necessarily mean the patient doesn't have MAFLD. So our patient had an abdominal ultrasound. He's got fatty infiltration of the liver, but no radiologic evidence of cirrhosis or portal hypertension. The liver is smooth, the spleen's not enlarged, so all of those things are reassuring. And again, really important not to put it down to being fatty liver when the LFTs are super high. The most common derangements we see are GGTs elevated, ALT predominantly elevated more than AST. Always take a drug history as well for herbal and over-the-counter medicines, which can present very similarly. If we look across the globe, MAFLD is definitely becoming the most common cause for chronic liver disease development. It's not only a disease in the West, it's a disease in many other countries now, and the prevalence of this is increasing at an alarming rate in parallel with rates of obesity and type 2 diabetes. And you can see that there's a chart on the right-hand side that demonstrates that nicely. And all the publications now in hepatology have really shifted away from being about viral hepatitis to being more focused around metabolic associated steatotic liver disease. It's becoming the #1 cause for liver transplantation and the #1 cause for development of liver cancer, which is quite terrifying. So how do we identify patients at risk of advanced liver disease in primary care? First of all, what you want to do is you want to work out whether you're dealing with a patient who has MAFLD, yes or no, to start with, based on what we just discussed. And then you want to work out what's their risk of having fibrosis, significant fibrosis. And a way to do that is, what I would suggest you do is do a FIB-4 score. So a FIB-4 score is a score that you can find online. It's available on medcalc.com. And I think I have in one of the slides what parameters it factors in. But basically that score will tell us whether the patient is at low risk of advanced fibrosis and can be managed in primary care, focusing on managing risk factors such as managing their diabetes, hypertension, encouraging weight loss, or whether the patient has significant risk of having advanced fibrosis and should be referred on to a hepatology service for assessment. There's also a group who will have a FIB-4 score in the intermediate range between 1.3 and 3.25. That patient should have a formal FibroScan done to better assess their degree of fibrosis, and then based on that, either be referred back to management in primary care or referred to the hepatology clinic for further assessment. So this is the FIB-4 score on the left. It factors in age, serum, AST, ALT, and platelet count. And then you can also use the MAFLD fibrosis score, which is more I guess, validated for patients with MAFLD, but I tend to use the FIB-4 score. It's a bit simpler. And it's validated across different causes of liver disease. So I tend to use that one. We've also in this presentation included the QR code, so it's easy for you guys to be able to access them. But have a think about the score that you're getting. Our patient has a score of 1.45, so fits right down the middle category here and should really be having a FibroScan to assess his degree of fibrosis. And so we go on to do that. FibroScan, I don't know if all of you have kind of had interaction with a FibroScan machine, but it's very, very similar to an ultrasound machine. It's probably a 15-minute test. I might just get Nathan, who's our liver clinic CNC, just to maybe talk very, very briefly, maybe just about what FibroScan involves for the patient. And then I'll take over from Nathan again. I don't know if he's able to do that for us.
Yeah, sure. Thanks, Jason. So the patients are invited into the clinic for FibroScan to determine their stage of fibrosis. FibroScan is very good at determining lack of liver damage versus extensive liver damage. It's not so great at determining the stages in between. But if you've got concerns about a patient possibly having advanced liver disease, and Jason mentioned earlier about ultrasounds sometimes not being 100% at picking up steatosis, conversely, sometimes when steatosis is seen on an ultrasound, it can also mimic some of the signs of advanced liver disease, like coarse endocotexture and a nodular sort of contour to the liver. So sometimes a FibroScan can give us a little bit of reassurance that a patient doesn't potentially have advanced liver disease when an ultrasound might be suggesting that they do. As Jason said, it's a pretty quick procedure. Patients fast for 3 hours prior. We lay them down on the table and hold the FibroScan probe between their intercostal spaces on the right-hand side of their body over the liver. We get 10 readings, and that gives us a median score. And then that median score is compared on a range from F0 to F4. So lack of liver fibrosis through to liver cirrhosis. And each underlying etiology, so alcohol versus fatty liver versus Hep B versus Hep C, might place someone in a different place on the scale. So the same score for one person might not indicate the same level of fibrosis as another patient. Thanks, Jason.
Perfect. Thanks, Nathan. So this is a skill that our nurses in our liver clinic have kind of acquired over time with some training involved to be able to accurately get a reading for patients. So what we look for quality is a very tight interquartile range of the readings. And we look for at least 10 valid measurements to be able to accurately determine the fibrosis score. And then we use this chart, which Nathan was alluding to on the right-hand side, to determine whether they're F0 to F1, F2, F3, or F4. And that number, I guess, or that criteria varies depending on the indication that we're looking at. And we can also use the CAP score, which tells us their steatosis grade. Not perfect, but it does tell us whether they have significant fat infiltration of the liver or not. Nathan was going to talk to this, but I might just help out with this part, just to say that we have a fatty liver pathway at St. George Liver Clinic, where if you feel like a patient has underlying fatty liver disease and they fall in that intermediate range and require a FibroScan, you can refer directly to that pathway. They'll be assessed by one of our CNCs. And then what will happen is they'll have a FibroScan, they'll have a metabolic assessment. So we use a body composition scale, which you can see on the right-hand side there. It's quite motivating for patients to get this printout that they get to take home with them. That tells them their BMI and their visceral fat rating. Probably the most confronting part of it is their physique rating, which they get at the bottom there, quite scary. But patients do like having this assessment done. They also get a potential dietitian review, depending on whether they fit criteria or not. And obviously patients with significant fibrosis are then managed in the liver clinic, and patients without significant fibrosis are given recommendations for management in primary care. Why do we worry so much about this? Well, there is the risk of progression from having just the plain steatosis to steatohepatitis to fibrosis and cirrhosis, and then the complications of that, including HCC. But that progression occurs very, very slowly, fortunately, in patients with MAFLD. So it is really, really important. Although we find MAFLD in a lot of patients, it's really important to pick the ones that are progressing along this pathway, identify them early, so that we don't run into problems later on. And just very briefly on management, dietary and lifestyle modification are the mainstay of treatment. We recommend mostly a Mediterranean diet because that's where the data is at the moment in terms of dietary modification. We might get some questions about that later. We really try to focus on tight control of metabolic risk factors, particularly the management of diabetes, I think is the key one that's been associated with progression of fibrosis and development of liver cancer in patients with MAFLD. Vitamin E is sometimes used in patients with, particularly with elevated LFTs in the context of MAFLD, but the studies have only supported its use in patients without diabetes. And then there's emerging evidence for the role of GLP-1 receptor agonists, etc., in select populations, but access remains an ongoing issue, as you are all aware. And then there's clinical trials that we run in the liver clinic as well, looking at newer agents. But fortunately, the clinical trials, thus far, the results of those trials have been disappointing in this condition. Patients with MAFLD actually end up dying from other factors, not their liver disease in the end, when you look at the data. So they usually, unfortunately, pass away from cardiovascular disease and cancer. They're the kind of the top two causes of death in this population. So although we're focusing on liver, it's important to identify that if you are managing these patients, to think about their cardiovascular risk and to think about their cancer risk, because they are significant contributors to mortality. So just some take-home points from this case. MAFLD is rising in the community. It's an important risk factor for development of advanced liver disease, cirrhosis, and HCC. Please identify patients at risk in primary care using the FIB-4 score. Encourage our patients to adhere to dietary and lifestyle modification and continue to motivate them. And try to be very aggressive in managing metabolic risk factors, and think about cancer screening in these patients. Okay, for this next part, I might pass back over to Nada.
Yeah, no, thanks so much. That was really perfectly timed. I'd like to introduce Hester to keep going and introduce our next case. Thanks, Hester.
Thank you so much, Nada, and thank you, Jason. I should flag that with our first case there, who was telling us that he was having 3 standard drinks, not drinking very much in a week, that you do need to just be aware that sometimes, as Jason said, people do underestimate. And there is no safe drinking level. Even at those low levels of alcohol intake, there are significant harms, and we're becoming more clear on the risks of cancer and of other issues. Alcohol, certainly liver disease is important, but other issues as well. I'm just trying to work out how to make this go forward. Yes, here we go. So this is case 2. It's a 45-year-old Caucasian female, let's call her Mary, who works full-time in marketing and comes in for a health check. You do some bloods and she's got deranged LFTs. So she's presenting for a general health check, and you found these liver function tests that are abnormal. And so you ask her about the lifestyle issues. As Jason said, really important to think about diet and all the other issues that can damage the liver. But with this one, she's drinking a bottle and a half after work. Starts drinking after work, working full time, no blackouts. She always remembers what she's done. She manages only 1 alcohol-free day a month. She feels guilty about her drinking and is thinking maybe it would be a good idea for her to change this. She's a non-smoker. Now, certainly on this slide, we've got 90 grams. So 10 grams of alcohol is around about the same as a standard drink. I find that it's useful to be able to talk through with people what a standard drink actually looks like. And the ones that I always remember in my head is 30 mils for spirits, 60 mils for a fortified wine, 100 mils for a wine, and a midi for a full strength beer. But it depends on what the person is drinking. And I do find younger people are pretty good with their standard drinks, particularly with the premixes where they will say, I have a beer, and on the can it says 1.4 standard drinks. It is important to find out how much and how often. And it's also important to understand the environment and what's happening. And what turns out with Mary is that she's doing this as she cooks dinner at night and gets through the bottle and a half, and her partner drinks the other half of the bottle. The audit is a really great screening tool. This is from the World Health Organization. And what we can see with this is that when Mary does her audit, she's got an audit of 18. So this is significant. It tells us that she's drinking at risky levels. She's drinking at potentially at hazardous levels, and potentially at dependent levels. The other thing I just want to flag here is there is a really nice program that's been put together by Adelaide Uni called the Assist portal. And it actually runs through the audit, but it also runs through a similar screening tool for all other substances as well. There's one that you can get on your phone and people can fill it in themselves, or you can fill it in your consult with patients. So a little aside, but a really great tool that you can find. So if you just look up eAssist or Assist, you'll find it online, and it's the www.assistportal.com.au. Really great, and a really great one for people to be able to use themselves as well. So she's got a total of 18. That is a concern. And we do need to think about withdrawal. We do need to think about whether it is possible that Mary has alcohol dependence. Is she at risk of dependence? Has this happened in the past? Has she ended up getting sick as a result of trying to stop? What do you notice if you don't drink is the question that I would be asking Mary. Does she get, till 6 p.m. and then the craving is just overwhelming? What happens on that one day of the month when she doesn't drink? What does she notice? Does she start thinking a lot about alcohol? Does she start feeling anxious or stressed or sweaty? Does she sleep poorly? Has she tried to cut down? She's talked about, I'm thinking I probably should change this. When she's tried, what has happened? It's likely that she may either feel no withdrawal or have mild to moderate withdrawal. And that level generally can be managed in an outpatient setting. And it's certainly something that I have done many times in a general practice setting in collaboration with my local pharmacy. So getting Mary to present daily to the pharmacy to pick up diazepam, daily doses of diazepam over a 4 to 7 day period. What you don't want to do is give Mary a pack of 50 Valiums and say, go away and sort it out on your own. It doesn't work. And poor Mary can end up finding that the diazepam is very moreish as well and end up with a diazepam issue. The other thing is to think about thiamine. So even with good diet, if you are drinking a lot, you don't absorb thiamine. So thinking about thiamine as an option. If somebody has had a significant withdrawal in the past, it may well be that they need an inpatient admission. So if they're homeless, if there's other issues going on, if they have other health issues that put them at risk of medical complications, or they've had a serious withdrawal where they become very unwell, they've had withdrawal seizures, or they become delirious, it's really important that they are seen and managed in an inpatient setting. So that's the time to refer them on. And if for any reason you can't manage the withdrawal, refer them on. The one thing that I would say, which I always say to people, and they kind of go, what, Hester, what are you talking about? Is if you have someone that's dependent and is at risk of withdrawal, tell them, don't do this on your own. Keep drinking until we can organise a safe, effective withdrawal for you, because you don't want people to come to harm from withdrawal. So just looking at the liver function test. So you can see, once again, we've got some tests over time. And you can see that we've got the AST, the ALT, and the GGT are the ones that I'm most interested in. So we'd really, once again, the GGT is high, and that's the flag, and it's not always there. And as Jason said, you really do need to take a good history, because sometimes these can be totally normal, but you've got a significant alcohol history. But the GGT is high, and that suggests that there's been drinking in the last day or so. With the AST and ALT, as Jason said before, with alcohol, it tends to be the AST is higher than the ALT. And my way of remembering that is that AST is the one that makes you pissed. So that's the way that I remember it. You know, so once again, it's looking at what is her risk. And if we look at the FIB4, sorry, for liver fibrosis, it's 2.8. So what they're saying is that there is some fibrosis. Jason, I'm going to have to ask you to step in with this one. Because really, I'm concerned about her drinking, and I'm concerned about the level and wanting her to change. But I wouldn't be thinking, geez, I need to get her to a liver specialist at this point. Would you be suggesting that?
No, I think you're on the right track. So I think, yeah, with that score, it kind of points to further maybe primary care assessment, maybe consideration of a FibroScan being the next step.
Yeah, the only issue that we have in general practice is FibroScans aren't covered under Medicare. So not yet anyway. But certainly, I mean, my focus is on let's change this behavior, because if that is the treatment for alcohol-induced liver damage, is getting the alcohol out of the picture. Okay. So once again, we've got the beautiful chart that Jason brought up before. And once again, it's in that kind of mid-range. And my focus is on getting that alcohol under control. And that may well mean a referral to drug and alcohol service to help the person do that. And if things don't settle, or if they continue to have very abnormal liver function tests, getting them checked by Jason and his team is a great idea. And also looking for other causes, as Jason mentioned before case 1. So yes, here we go. She has long-standing elevated liver function tests. Was also told some years ago that she had MAFLD as well. No family history of liver disease. Nothing else on investigation, on examination, other than a bit of Palmer erythema. So once again, the liver screen, the abdominal ultrasound, FibroScan, we've talked about that. And so there she's got an abdominal ultrasound with a fatty liver with smooth contour. Looks pretty good. And we've also done a liver screen. So we haven't found any hepatitis B. We haven't found any hepatitis C. There's no autoimmune and nothing else going on there. So really, once again, the culprit here is the alcohol. We've got the FibroScan sitting here. So she's in that kind of area here where there's a little bit, potentially a little bit of fibrosis there. What I would be saying to someone like Mary is, if we change this now, this will improve. Your liver is incredible and it can heal. So this is a really good time to be making this change. Let's work on this together. This is important. It's going to help you lose weight. It's going to help you feel better. You're going to sleep better. Your stress will be better. Your anxiety and your depression will be better. Your husband, who's probably nagging you because you're drinking so much alcohol and it's expensive and he doesn't like you doing that, may well improve your relationship as well. So really, really important. We've got another one of these. Sorry, Jason, I'm not sure why this one is here.
I think that one was just to say, so this patient probably could be, like you're saying, managed in primary care, and we're trying to motivate patients with regards to alcohol abstinence. So I think, that was kind of the point of that one.
Yeah, totally. Look, and I think the other thing is that it's hard for people to say no to alcohol for the rest of their lives. But what I would say for Mary is, let's give your liver a break. Let's actually rethink your relationship with alcohol. And it's really common these days that people, after having had a break from drinking alcohol, will say, you know what? I don't think I'm going to go back to drinking because I feel so much better. For us in a general practice setting, opportunistically screen everyone from age 15. Make it part of your lifestyle assessment. How much do you drink? Using the tools like the audit or the audit C and liver function test can be useful, but flagging, once again, the liver function test may be normal. They don't exclude it, but it's an important thing that can help drive change. As I said before, alcohol causes a wide range of health issues. It is a toxin. Ideally, we would not drink at all. Many of us do. But really think about the role that alcohol has in your life and making it a sometimes thing rather than everyday thing. Using the biochemical markers can be helpful, not diagnostic, but once again, it's a driver for change. Your liver is not coping with this. This is a good reason to change this. Using our motivational interviewing skills, and if someone really struggles to change it, getting some counselling from a counsellor who has experience and expertise in supporting people to manage their change in alcohol. Consider dependence. It's important to diagnose it because people do need withdrawal to successfully stop. When people have stopped, consider the relapse prevention pharmacotherapies, things like naltrexone and acamprosate, or Rivia and Campril. They're not used as much as they probably could be in our setting. They are safe, they are effective, they're really useful. We also do have disulfiram or antabuse, but that's a bit more of a specialist medication and would certainly be third line. But really think about the option of these to help people change and maintain that change in their drinking. And referring to your local alcohol service, you're very lucky in Southeast Sydney that we have the GLAD team, if I can make it move, the GP liaison in alcohol and other drugs, which works collaboratively with GPs in Southeast Sydney and from St Vincent's, and also from Sydney Local Health District. And they actually have a full complement of staff of nurses running those roles. All this information is available on Health Pathways. So really encourage you, if you're not sure, to get in contact with the GLAD nurse in your LHD area. They are brilliant. They're really, really helpful, and they can come in and visit your practice, support the person to treatment, give you advice and support as you need it. I'll leave it there.
Lovely. Thank you so much, Hester. And I completely agree with the GLAD service. I use it a lot, and it's incredibly useful for our patients just to, cut out any extra sort of waiting time and get a real idea of how we can help. I'll just hand back to Dr. Behary and Nathan for the last case. Thanks.
Thank you, and thanks, Hester. That was an excellent tour de force of alcohol and alcohol-related liver disease. We're going to change tact a little bit and talk about, just very briefly, about hepatitis B and C in primary care, and then a little bit about HCC towards the end of the talk. Okay. Sorry, there's a bit of a delay moving slides. Yep. Okay. So this is case 3. So case 3 is a 60-year-old gentleman. Again, has had long-standing abnormal liver function tests. Otherwise, well, he migrated from China back in 1990, and he also has a history of intravenous drug use many years ago. Yeah, I'm not able to actually move the slides. I might get someone to help me take control of the slides again.
Jason, I'll help you. I'll just go back
Thank
a
you.
few slides.
Thank you so
We'll
much.
just get back a few.
There's a bit of a lag, and then it kind of just skips forward.
No, that's fine. So we're up to here.
Yep. All right. Fantastic. So these are the liver function tests that you have in front of you. So you can see the most recent ones in January, and predominant transaminitis. So this patient has an ALT of 220, an AST of 100, and ALK Phos and GGT are slightly elevated, not terrible though. But the key things that are kind of standing out to me when I look at this is his INR is 1.3, has a slightly elevated bilirubin of 22, and low platelets of 150. So again, we're thinking with the predominant transaminitis, probably and more with an ALT of more than 200, we are thinking around the viral hepatitis route, particularly given the history that you've taken from the patient. And then putting those numbers into the FIB4 score, he does have an elevated score there, suggesting further assessment is needed. Go to the next slide. Again, we do the three things that all hepatologists do when they first see a patient. So we do a liver screen, an abdominal ultrasound, and then we consider a FibroScan. And this is what comes back from his viral hepatitis serology. So he's got his hepatitis B surface antigen positive, his E antigen positive, and he has an elevated hepatitis B viral load of log 7. His hepatitis C antibody and PCR also positive. His liver screen is otherwise negative, so he's got co-infection with both hepatitis B and C. I just wanted to kind of just very quickly talk about interpreting serology for viral hepatitis. I've got a table for hepatitis B up the top and hepatitis C at the bottom. Really what you want to look at is you want to look at the surface antigen, and you just want to know, is that positive or not? If it's positive, the patient has chronic hepatitis B by definition. That's really the key one to be looking at. The E antigen status tells you about active viral replication. So patients who are hepatitis B E antigen positive tend to have more active viral replication than the counterparts who are negative. But irrespective, in those patients with a surface antigen that are positive, always do a hepatitis B viral load to confirm that that active replication is there. Sometimes we see patients, very quickly I'll mention this, sometimes we see patients who have had previous exposure to hepatitis B. So their surface antigen is negative, but they have their core antibodies positive. So that tells you that they've had previous exposure to hepatitis B. That group of patients is not at risk of developing advanced liver disease, but we do assess them in different contexts. For example, when they're requiring immunosuppression because they're at risk of reactivation. So it's a different group of patients. So again, just focus on the surface antigen. You want to know if that's positive or negative as your key starting point, and then the viral load from there. With hepatitis C, the antibody in patients who are exposed to hepatitis C will always be positive. But it's important to do an RNA level, which will tell you if there's active viral replication or not. Genotyping is not done now because with our therapies, the genotype doesn't really influence what therapy we choose anymore. Talk a little bit about that later. Go to the next slide. Again, this is just showing you the phases of hepatitis B. The first, all these patients in the first 4 patients have chronic hepatitis B, but then the first 2 patients up the top have E antigen positive. So they tend to have a high viral load. Some of them will have an elevated ALT, not all of them, but the ones with an elevated ALT have active hepatitis and their risk of developing fibrosis is higher. There's also the patients with the E antigen negative group who have a lower viral load, but some of those patients will still have an elevated ALT. And they're the patients who have mutations. They have a fluctuating course and they are also at risk of developing liver fibrosis and more advanced liver disease, but probably at a slower rate than those with antigen positive disease. We'll go to the next slide. So really the ones that you want to consider for treatment are patients who have an elevated ALT, very high viral load, and have some evidence of fibrosis. Usually based on FibroScan. They're the ones that are at risk of developing more advanced liver disease and liver cancer. But usually that assessment for treatment is usually done in the liver clinic. We do an ultrasound for our patient. He's got some steatosis, so not uncommon to see that as a confounder in these patients. But the key thing is that his liver is nodular, and it looks like he's probably got more advanced liver disease, at least based on what we can see with the ultrasound. Fortunately, there's no splenomegaly or other evidence of clinically significant portal hypertension. Go to the next slide. He has a FibroScan, and you can see the reading here, super high, right? So this gentleman's FibroScan score is 36 kPa, indicating that he's got cirrhosis. And he meets criteria for both Hep B and C on that chart there for having F4. Okay, next slide. So just a few slides about hepatitis B. Again, treatment should be considered in key groups of patients, because it's important to know that treatment is lifelong. Once you start patients on treatment for hepatitis B, you're essentially committing them to that treatment for life. So really the key patients that we should be considering are those with high viral load, elevated ALT, and or significant fibrosis, both in the e-antigen positive and e-antigen negative group. Patients with liver cirrhosis, by definition, should be treated for their hepatitis B, irrespective of their viral load or ALT. And then there are some other special situations where we consider treatment. For example, in pregnancy, particularly in the last trimester, in patients with very high viral load, we treat for a period of time to prevent vertical transmission to the fetus. Patients who are embarking on immunosuppression or chemotherapy, we treat those patients. If there's a family history of cirrhosis or HCC, our threshold for wanting to treat those patients is low. And also if they have extra hepatic manifestations of hepatitis B, which are uncommon, but do occur, and in that scenario, we would treat those patients as well, consider them for treatment as well. Next slide. There are two key drugs that we use for treatment for hepatitis B, and I'm sure you've seen patients on these, entecavir and tenofovir. I'll just go through them. So basically, they're both very, very safe. They're very effective. The risk of resistance with these treatments is extremely low and much lower than previous treatments, such as lamivudine, which was a treatment we used to use some time ago. The key differences are that entecavir doesn't have issues with bone causing osteoporosis in patients. And that's a key advantage of entecavir. But the disadvantage of it is that there's limited data in pregnancy. So for young women who are potentially embarking on pregnancy, we would choose tenofovir as our choice. Those patients need regular monitoring for bone mineral density loss, and they also need monitoring of calcium, magnesium, and phosphate, because there is a risk, very low risk, of renal tubular dysfunction and electrolyte disturbance. But in general, these treatments are safe and effective. And I think the biggest challenge that we have is reminding patients the importance of being adherent to treatment and remaining on treatment. Because what can happen is sometimes patients are on treatment, when they withdraw therapy, they can have a flare of their hepatitis B, and that puts them at risk of complications of decompensation and so forth. So we really want to be selecting our patients appropriately, making sure that our patients understand the importance of compliance with therapy, and then regular monitoring after that to make sure they respond appropriately. Go to the next slide. Nathan and our team are very, very proactive at the moment in screening patients to identify patients at risk of hepatitis B. So that involves community screening programs and involves obviously interacting with primary care physicians to be able to do that. We have in our liver clinic a shared care model between our nurses, GPs, and hepatologists in the clinic, where we can share patients who have chronic hepatitis B on treatment who will remain stable, to ensure they have 6 monthly blood tests and at least a yearly hepatitis B DNA level. And we also want to make sure that we're identifying patients who also need to be enrolled in HCC screening, because early detection of HCC is key. Next slide. For hepatitis C, we're really fortunate that, as you all know, with our DAA therapies that were PBS listed some years ago, there's been a significant decline in the estimated number of Australians living with hepatitis C. So the challenge now with hepatitis C is really not about treating patients, because our treatments are so effective. Really, it's about identifying those patients who are still in the community with hepatitis C, unbeknownst to anyone that they have the infection. And so there's an estimate of about 120,000 Australians still living with chronic hepatitis C in the community. And you can see how much treatment initiations have occurred over time and how that's dropped off significantly. And now the challenge is kind of trying to find those patients who have the who are viremic but are unbeknownst to us. And Nathan's been working very, very hard on that, trying to identify those patients. And we're doing some work in screening blood tests in patients who come through emergency to identify some patients with hepatitis B and C. Next slide. I might pass over to Nathan to talk about hepatitis C management. Nate, are you able to go through this table for us?
Yeah, absolutely. Thanks, Jason. So as Jason said, the issue these days isn't treating Hep C because we've got some very effective cures and have had since around 2016. And the numbers of people in the community with Hep C have declined drastically because of those treatment options. And Jason mentioned some of the nationwide numbers. I know that the Ministry of Health tells us there's still around 5,000 people with undiagnosed or untreated Hep C just in the southeastern Sydney LHD alone. So there's still plenty of people requiring treatment. There's no reason why anyone should have Hep C these days because, again, the treatments are so effective. And I often tell patients that, if they have an active Hep C infection, that treating their Hep C is probably the easiest thing and the simplest thing that they can do to improve their long-term health outcomes and avoid, the nasty side effects like liver cirrhosis and development of progressive liver disease and liver cancer that can come with those. So there's two medications that we commonly use these days. One is called Epclusa and the other is called Mavorite. Epclusa is a single tablet once a day for 12 weeks. Mavorite is 3 tablets once a day for 8 weeks. So there's a shorter and a longer duration course. Some people just want to get it over and done with quickly and we'll go with the 8-week course. Some people already have a large pill burden and will opt for the 12-week course because it's only a single tablet once a day. We can do things like arrange dosing through OST pharmacies. If there's patients who are on methadone programs or the like, they can have their Hep C dosed through their community pharmacy, or we can provide the medications through the liver clinic and monitor them through the liver clinic as well. I guess the important things to mention about the new treatments are that they're completely free to anyone with a Medicare card, which is wonderful, as Jason said, listed on the PBS. There's no restrictions anymore. The older interferon type treatments, they're a bit selective about who was able to have them. They were dependent on genotypes. The side effect profile of interferon, people still tell me horror stories about being treated with interferon years ago. The new DAAs have an amazing side effect profile. Most patients who take them come back to me and tell me they wouldn't have ever known they were on them. The worst that I've seen really is, maybe a mild headache or a bit of stomach upset, a bit of fatigue in the first week. But actually, most patients that we treat come back after a week and sort of say to us that they haven't felt this good in a long time. That kind of re-energized feeling that people have when they start to reduce their viral load and start to eradicate the virus can be huge for people. As can treating a virus that they've had hanging over their head for decades in some cases. The personal effects that I've seen, people in tears at being told that they've been cured of Hep C, finally they've put it off. And then once they've been treated, they've realised how easy it was and it changes their life. It's really amazing. Some of the things we'll consider when we're prescribing treatment are the level of liver disease the patient has. If a patient's cirrhotic, we would almost definitely want to manage them through the liver clinic, manage their treatment through the liver clinic and monitor them during their treatment period. But there's obviously a place there for GPs to assist with that monitoring as well. Renal impairment can cause us to choose one medication over the other. There's one that's better renally tolerated. Decompensated cirrhosis is a whole nother story again, and those people would require some very close on treatment monitoring. But if you've got a patient who is relatively well otherwise, we do a FibroScan and they have no signs of liver fibrosis. They might have some LFT derangement. They're generally otherwise well. Some of these people can be quite young or they can be a bit older. Almost no on-treatment monitoring is required because we know these medications are so safe. Literally millions of people worldwide have been treated with these DAAs. As I said, they're pan-genotypic, and I guess the most important thing about these treatments is they're 95 to 98% effective. Like, I'm not too sure Jason's experience, but I've been treating Hep C now for about 4 years, and I haven't had a single patient that we couldn't cure of Hep C. We've had, a couple of curly ones where we've had to have a couple of goes at it, but these medications are absolutely phenomenal in what they can offer us, and they can help us towards that WHO goal of eradicating Hep C as a public health threat by 2030. That's what we're all working towards. As Jason said, we do a lot of community screening to try and help with that. But I think, GPs play a very important role in helping identify those people with risk factors and doing some viral Hep screening to find those sort of missing cases that we're not currently aware of. Thanks, Jason.
Thanks, Nate. So moving back to our patient has compensated liver disease. His hepatic synthetic parameters, well, he doesn't have evidence of portal hypertension, no ascites, encephalopathy or varices. We always want to aim in patients with liver cirrhosis to prevent hepatic decompensation. And we also want to prevent HCC. So I think that's our next slide. Oh, no, I'll just talk about this very quickly. Child-Pugh score. So this is a way of kind of assessing a patient with liver cirrhosis and understanding what their mortality might be. So you might see Child-Pugh in letters, and it's a very easy calculation to make. But really, the score will tell us how likely the patient is to succumb from liver disease related complications. So a patient with a Child-Pugh of 5 or 6 is compensated, and a patient with a Child-Pugh score of 10 to 15 is decompensated by definition. And obviously patients with decompensated liver disease have a significantly worse mortality than those with compensated disease. So there is that spectrum in patients with liver cirrhosis, and there's been lots of studies more recently trying to identify patients at risk of decompensation and trying to prevent their first episode of decompensation, which is the key. And I haven't included it in these slides, but we are using carvedilol. Carvedilol is a non-selective beta blocker that's been shown in many recent studies to reduce the risk of hepatic decompensation in patients with clinically significant portal hypertension. So reduce the onset of ascites and reduce the risk of variceal bleeding in patients with clinically significant portal hypertension. So we are starting a lot of patients on carvedilol now. And sometimes in patients who are on other beta blockers, we do sometimes switch them over from their metoprolol to carvedilol in consultation with their cardiologist if they're on that for another indication. Next slide. So just very briefly talking about HCC screening. So HCC is the most common cause of primary liver cancer. Obviously, the other one is cholangiocarcinoma, but HCC definitely more common. It is the fastest rising cause of cancer-related death in Australia. So that is very significant. The problem with HCC is that it's often diagnosed late, and when it's late, as in multifocal disease, then patients have a poor prognosis as a result of that. Major risk factors include obviously having viral hepatitis, but that's becoming less of a risk factor now because we're treating more of those patients. And as I said before, MAFLD and alcohol are becoming the biggest risk factors and the drivers for development of HCC in our patients. Slide. So I just put this table in, just comparing it to lung cancer. So definitely lung cancer accounts for the most number of deaths in Australia by far. But if you look at what type of cancer is increasing the most over time, it's definitely HCC. So there's been a greater than 40% increase in HCC incidence over the last 20 years, whereas other cancers such as lung cancer, that percentage is falling over time. So that's why there's been a lot of studies and work done in trying to identify patients early and treating those patients to prevent more advanced disease in the future. Slide. So And the key thing is really HCC screening. And by HCC screening, what we mean is by doing an ultrasound and alpha fetoprotein level on a 6-monthly basis. So the patients that we consider for that are all of our patients with liver cirrhosis, regardless of the underlying cause. Patients with chronic hepatitis B who don't have cirrhosis, there are certain criteria for that. So Asian men over 40 years of age, Asian women more than 50 years of age, patients from African descent of more than 20 years of age, and if patients have a family history of HCC, all of those patients with chronic hepatitis B should be enrolled in screening. Patients with advanced fibrosis, meaning F3 fibrosis, there's limited data around that, but we are becoming more and more concerned about that group of patients who are not quite cirrhotic but have F3 fibrosis, particularly in the context of MAFLD in developing HCC. So we are enrolling patients who are at higher risk in HCC screening. And then there are some special groups as well. So transplant candidates or recipients of liver transplants, family history of HCC, we would screen them. Patients who are Indigenous and some migrant HBV populations are considered for screening. And then patients with HIV and Hep B or Hep C co-infection are also screened on a 6-monthly basis as well. Next slide. GPs can definitely assist in screening. As you can imagine, having a blood test and an ultrasound every 6 months is a big ask of patients. So adherence rates are very, very poor. So we need to, be proactive in encouraging patients to, as best as they can, adhere to the 6-monthly guidelines. And also, as we're doing that, reinforcing that an earlier diagnosis is linked to better patient outcomes, as we are now offering lots of curative therapies for HCC, including surgery, liver transplantation, and some local regional therapies are also curative. So finding HCC early is essential. Next slide. So just take home points from all of those last cases that we did. Not all mildly abnormal LFTs are due to MAFLD. Think about patients' alcohol consumption, their underreporting of that, and make sure we're proactive in managing those patients. Always think about screening patients for hepatitis B and C. We're identifying more and more of those patients, but we've got to be proactive about looking for those cases. Refer to a hepatologist when you need to, or just pick up the phone and have a conversation with one of us. We're always friendly and happy to give advice on the phone. We really want to prevent development of cirrhosis. And then in patients with cirrhosis, we want to prevent decompensation, which is linked to mortality. So that's the key objectives. And HCC screening for patients at risk is essential. And we really want to make sure that we don't miss any HCCs that present late. And we're 8:08, and that's the end of the presentation. So we have some time for questions, I think.
That's fantastic. Thanks so much, Jason, Nathan, and Hester. I learnt quite a lot in a very short space of time about the liver. And I guess I can have a quick look to see if there's anything in the Q&A, and it'd be a really good time for our audience to type in any questions that they're interested in getting answered into the Q&A chat. And I guess we can always
Can I ask a question? I've got a question for Jason, because it seems like there's NASH, there's MASH, there's NAFLD, MAFLD. How are they different?
Okay. It's a really, really good question. And so we used to talk about non-alcohol related steatotic liver disease, NAFLD, right? But then there's been in the last couple of years, there's been a change in the definition of what that means. And it's very, very technical, and probably for the purposes of primary care doesn't make much of a difference. But what I like to think of it is a patient with MAFLD, that's the umbrella term, has fatty liver disease, right? And then within that, you can get patients with just steatosis, so they've just got a fatty liver. The ones with MASH are the ones with hepatitis, steatohepatitis. So they're the ones that have inflammation, so abnormal liver function tests in the context of fatty liver disease. They're the MASH patients, I guess. So they're the patients that are higher risk of developing problems later. like fibrosis and complications related to the liver disease. So I guess that's a trajectory, going from having fatty liver with no elevation in LFTs to developing hepatitis and then the complications associated with that hepatitis later on down the track. I think that's probably the easiest way to think about it. Yeah.
Thanks so much. Great question, Hester. I've got a question in the chat. Is the shear wave elastography done in private clinics, not the FibroScan, reliable?
Yeah. I can answer that one. Look, there's been some studies comparing the two, and FibroScan is definitely more accurate in staging fibrosis. There's a lot of, as we all know, with ultrasound, there's a lot of kind of inter-user variability, I guess is the best way to say it. And the same thing goes with shear wave elastography. So you can see with FibroScan how we are using someone who's trained, who focuses on doing FibroScan regularly, who then does a number of readings and with a very tight interquartile range to be able to accurately stage fibrosis. So I think with shear wave elastography, those kind of quality indicators are not adhered to as much. And as a result, sometimes the results are a little bit more varied. So I think it depends on the provider. So I wouldn't say it's a useless test to do. I think if things don't fit, like, and we've seen this before, where you have a patient with has a low FIB4 score, but they're fibrous, then shear wave elastography tells you they've got cirrhosis. It's probably that type of patient where there's disconcordance between those two that you tend to have a FibroScan to look into. I wouldn't necessarily always rely on the shear wave elastography as being entirely accurate. I guess that's probably the best way to explain that. Yeah.
I think also, Jason, shear wave is not validated, whereas FibroScan is. So we know that we can rely on a FibroScan result, and we very rarely see user error, as you say, or FibroScan results that don't agree with a liver biopsy if one happens to be done later.
Correct.
Yeah.
But I think Nathan, that's also because you guys are very good at it. Like, can you maybe just describe how sometimes they can be difficult and how you troubleshoot that?
Yeah, look, and sometimes we can't get a result for someone. Sometimes a large body habitus can be an issue. The liver's just too deep, and we can't get a reading. But we do have lots of ways of positioning a patient to try and get a bit closer to their liver. Saying that, you can have someone who comes in, skinny as a rake, and you can't get a reading for one reason or another just due to their internal sort of body architecture or the intercostal spacing or whatever it might be. But yeah, there's not too many that we can't get.
And how often would you do a follow-up FibroScan, for instance, if a person did have a higher reading than you would expect?
There's no data to kind of, it's really, really difficult. I would say at least 2 years. Sometimes we leave, for example, with patients with significant F3 fibrosis, we wanted to reassess them after being on treatment for hepatitis B, for example. We might do that in 2 years' time. But dynamic changes in FibroScan have been studied, and it's really, really hard to understand why some patients regress in their fibrosis and others don't. So using FibroScan as kind of timelines to assess that, it's really, really challenging. So there's not a good answer for that one, unfortunately. But I think using biochemistry and using the FIB4 score, and if you see things changing, you might go, oh, this patient didn't have significant fibrosis on a FibroScan some time ago. Now things have changed. It might be worthwhile at that point reassessing them with a repeat FibroScan then to make sure they haven't developed more significant fibrosis than previously.
Thank you. We've got a couple more questions. One is a comment just about how often you might get an isolated elevated GGT from medication. And I guess, how far do we go if we do have an isolated elevation of GGT? And do we have to cease medications that cause an elevation in GGT?
I'll answer that one as well. There are some medications that cause isolated elevated GGT, typically anticonvulsants can do that. sometimes antibiotics, statins. So it depends on an elevated GGT in isolation due to a medication, if we're very confident that the medication is a contributor, is unlikely to cause long-term issues. But I guess, for a patient that's on a medication that they don't need, then of course you would consider stopping it. But for example, someone who's got on an anticonvulsant, they've been seizure-free for a number of years, they have an isolated elevated GGT, that patient's very unlikely to develop significant fibrosis as a result of that isolated GGT elevation. I think the key thing is just making sure there's no other contributors to it. I think alcohol, for example, is one of them. And I think Hester was going to put a hand up for that. But just to say that, as she was saying, patients really, really underreport. They really do underreport how much alcohol that they're having. So it's really important just to be to keep that in mind. That could be part of the story that the patients don't want to disclose. Hester, did you want to add to that?
Yeah, look, I think it's, understandable that people may not realise that they need to tell us, or may not keep account of their drinks, or may feel a bit shameful or a bit anxious. I'm drinking when I shouldn't. And so it's really important the way you have the conversation is around, look, alcohol is ubiquitous. Lots of people drink alcohol. Sadly, it's a toxin and it can cause harm. It's important for me as your GP to understand those things that might be causing risk to your health. And I'd just really like to help you have the best possible health you can. Can you tell me about your alcohol use? Asking permission. Is it okay if I ask you? I've never had anybody say no, but it actually just sets up a conversation rather than a "have you been drinking again" kind of accusatory kind of feeling that people can sometimes have. I have one patient who was drinking 10 schooners a day, and every time I saw him, I'd say, "Can I ask you about your alcohol?" And he'd go, "Yeah, I know, it's still 10 schooners." So every time I saw him, I would just check in with him. And then it was about 3 years later, he went, "Hester, I know you've been asking me about those schooners for 10 years or whatever it was. I want to change it." So being open to it, flagging that as a GP, it's a really important part of your role, and it's what we do every day. And I'd have to say, I don't know about anybody else here, but I seem to spend most of my time as a GP talking to people about exercise, stress, weight loss, nutrition, stopping smoking, stopping drinking, stopping drugs, or changing that, because they have such incredible impact on people's health, and people feel so much better when they make those changes. So really just making it part of your everyday conversation, which is what we're good at as GPs.
That's so true. Thanks so much, Hester. The next question is, if someone does have a positive family history of hepatocellular carcinoma, do they need to attend to regular screening tests?
Yeah, it depends on the indication. So for hepatitis B, if a patient has chronic hepatitis B and a first-degree relative with HCC, that patient should be screened irrespective of their age. So that's important. But someone with, for example, a family history of HCC due to hepatitis C or alcohol or MAFLD, no. So it really is about the hepatitis B group that you would screen in that context. Yeah. So that they basically fall outside of that age criteria that we usually reserve for patients with chronic hepatitis B, which is 40 in men, 50 in women. So when there's a family history of HCC, we start that screening earlier. I guess is the best way to answer that one.
And do you do an AFP during your screening, or is it more just a 6-monthly ultrasound?
Yeah, it's definitely, the data definitely suggests doing both ultrasound and AFP. It's actually the ultrasound that's more important than the alpha fetoprotein level, because there are some hepatomas that are non-alpha fetoprotein secreting. So it's definitely the ultrasound that's the key part, but the AFP helps because sometimes, particularly in patients with fatty liver, it's sometimes difficult on ultrasound to appreciate if there's a true lesion or not. And sometimes the giveaway is the alpha fetoprotein's gone up, and then we investigate that and identify it. So it is definitely the combination of the two together that are important.
Excellent. I've got a random question as well, just about MAFLD. I guess just reading about treatments and you know, for us, it's going to become quite a significant issue in general practice, just looking at dysfunction and liver test abnormalities, but also looking at our patients. In patients who, you know, you wouldn't traditionally, you know, treat a blood pressure in, you know, for instance, those patients that have a normal blood pressure, normal cholesterol, but they are obese and they do have changes in their liver function. You know, what are your suggestions around, you know, using a statin or using a blood pressure medication and thinking about, you know, long-term coronary or CVD risk and thinking about the fact that that might be one of the, I guess, endpoints we look at for those patients? Or is that something that you think we should sort of take into consideration? Or is that something that we should just, I guess, monitor over a period of time?
Really good question. So you mean, so you're asking in someone who doesn't have the cardiovascular risk factors, how far do you take their cardiovascular screening in a patient with MAFLD? Is that,
Yeah,
yeah?
I guess,
It's a
yeah,
really, it's a really good question.
what do we do? What do we do with
Yeah,
a MAFLD
yeah.
patient?
I mean, I think it's having a high index of suspicion for them developing cardiovascular disease is the key thing. I think looking for the risk factors is really important, like making sure that their blood pressure isn't elevated, making sure their HbA1c is not elevated. Those things, honing in on those that's the key thing. I don't think there's a lot of evidence for starting an antihypertensive or a statin in patients who don't have hypertension or dyslipidemia in reducing their risk, but there are lots of non-invasive tests now that patients are having done that are assess their cardiovascular risk, like CTCA, for example, is one of them. I don't know what whether they're Medicare rebatable or not, but you should be thinking about that in your patients. You know, patients who are obese, have MAFLD, coronary disease is going to go with that, right? So that might be a patient that you want to do a stress test or a CTCA on to kind of risk stratify them from a cardiovascular perspective. Yeah, but I actually think getting the simple things right is probably the key. This is probably the harder bit. You know what I mean? The undiagnosed hypertension and the dyslipidemia, and then talking to patients about diet and lifestyle and trying to motivate them to do the right thing to reduce their risk. I think that's probably the harder bit.
Yeah, definitely.
That's
The
what we
lifestyle
see.
factor.
Yeah, yeah, absolutely.
Yeah. I've got a question for you, Hester. I just wanted to know a bit more about naltrexone and how what your uptake situation has been like. I think if you offer a client once they've completed their detox, or, you know, day 3, day 4 of an alcohol detox process, you know, how likely would most of your patients be to start naltrexone, and how long do you go for usually?
Yeah, a lot of people will start it, and generally, yes, we would start it towards the end of their withdrawal management. And you start it off at a half tablet for a few days. You check their liver function. Uncommonly, naltrexone can affect liver function, so it's good to chase that up. The tricky thing is if you do it again in a couple of weeks or 3-4 weeks time, if it's abnormal, is it because of the naltrexone or is it because they're drinking on top? Because you can drink on top of naltrexone. It doesn't cause any. It's not an issue, but it just means it's not working. The other thing is that it is a mu receptor antagonist. So anybody that is on an opioid, whether it's tapentadol or tramadol or morphine or codeine, you cannot use naltrexone. But it's actually people find it very easy to take. It's a tablet once a day, and it's sometimes when it can be really useful for people to be thinking, this is my reminder every day. I'm taking this every day. It's my reminder around how I want to change my relationship with alcohol. And I would generally keep people on it for 3 months, 6 months. Really, it's around working with them around how they feel they're managing their risk. So someone who always drank at the pub, are they going back to the pub? Are they doing the other behaviours that happened for them when they drank? Or are they able to go to celebrations? They've made a decision they want to be abstinent for a period of time, and they can go into situations where there are triggers and they're okay. Then they can look at actually stopping it. But it's a very individual thing. And as I said before, one of the hard things for people is to think, I'm never going to have another drink. And so we say, no, we're not talking about never. We're talking about a break. We're talking about giving your liver a rest. And the medication can help you do that. It stops the sense of reward. It stops that warm, lovely, geez, I want some more feeling. And it can be highly effective for people. Some people decide not to. And I will say to them, that's absolutely fine. We'll keep in contact. We'll keep working with you around how you change your relationship with alcohol. And sometimes they'll come back a couple of weeks later and go, oh, Hester, I think I should try that tablet for a little while. I'm finding it tough. And so it's, once again, it's another tool in your toolkit for people that are changing their drinking. Safe, effective, really consider using it. Sometimes GPs will say to me, oh, but it's, it's high risk and it's an authority prescription. It's not high risk. It's helpful. Prescribe it. Get some support from your GLAD nurse if you're concerned or want to ask some more questions, or there are other issues going on in the person's life that you need some help with.
Thanks so much. And just one more question in the chat that's sort of related is, what about binge drinking? What if you have a patient that has very high levels of episodic drinking? So you're drinking, once a month, but to, intoxication. Is there anything that we can do medication-wise to assist?
Yeah, look, we occasionally will try using naltrexone for people to use for high-level hazardous episodic drinking. So they're not dependent, or maybe there's a little touch of dependence there because once they start, they don't stop. There's not a great deal of evidence around the use of PRN, naltrexone. Anecdotally, sometimes I've found it helpful. Whether it's actually the medication or whether it's around the person going, I'm preparing to go out, I don't want to drink, I've taken my tablet, I'm not going to drink. If it's placebo, it's a pretty safe tablet. And if it works for people, that's fantastic. You can still, to my mind, you could still prescribe it on Medicare because you are looking towards achieving abstinence. So don't be concerned. And sometimes GPs will get concerned about the fact it needs to be part of a comprehensive program. Guess what? You as the GP are the comprehensive program. If that's appropriate, if it helps the person change their behaviour, that is absolutely appropriate and does fit the Medicare guidelines.
Thank you. I've got a couple more questions in the chat. I think the one that's popped out to me is the word Hep B carrier, I guess. Is there such a thing, and what do we do as GPs with respect to this term?
Yeah, it's really, I hate Hep B carrier term because it really doesn't tell us much. Like, as I was saying before, you want to know if the patient either has chronic hepatitis B or they've had previous exposure to hepatitis B. It's one of those two, isn't it? Obviously with the patients with chronic hepatitis B, that's the group that we discussed in the case. But patients who have been exposed to hepatitis B, meaning that their surface antigen's negative, but they've got their core antibodies positive, meaning that they've had exposure in the past, that group of patients doesn't require monitoring in that scenario. But it does become relevant, though, as I was mentioning in the talk, when they embark on immunosuppression. So, for example, prolonged high-dose steroids or therapies for, like biologic therapies for arthritis or for inflammatory bowel disease or chemotherapy. In that context, there's a risk of reactivation of the hepatitis B. The risk is small, but important to be aware of. And so in that group of patients, depending on what major agents are being used as part of the immunosuppression, we will start patients on treatment for hepatitis B, which they take throughout the course of their treatment. If it's for example, if it's chemotherapy, they'll take it throughout the course of their chemotherapy, and they might then take it for 6 to 12 months after to prevent their risk of reactivation, and then we'll stop their hepatitis B treatment at that point. But outside of that, the patients who have been exposed to hepatitis B in the past don't need monitoring or hepatoma surveillance or anything like that. Yep.
Thanks so much. And just one, I guess, yes or no, does metformin help fatty liver disease?
Oh, that's a good one. No, look, obviously metformin is used for insulin resistance, which is part of the problem that's kind of a confounding factor in MAFLD. It's not used for fatty liver per se, in the sense that it hasn't been shown in studies to reduce the degree of steatosis or fibrosis histologically or on imaging. but have a very low threshold for considering it in patients who have underlying insulin resistance and obviously in diabetic patients. But in patients without insulin resistance or diabetes, you wouldn't, recommend metformin for a patient with MAFLD in that context, I guess, is the best way to answer that, because evidence doesn't support that. Yes.
Excellent.
Jason, did you want to talk about the sort of increasing use of GLP-1s
Oh, yeah.
in relation to MAFLD?
It's actually, we're finding, at least anecdotally, we're finding an excellent improvement in patients' liver enzymes and FibroScan scores after being on a period of treatment. It's probably, the effect of it's probably driven by weight loss more than anything else. But looking at the studies haven't really proven that their use reduces at least histologic fibrosis yet. So the studies for that are still not there. But I mean, we are recommending it more and more for patients who are morbidly obese, who have struggled with diet and lifestyle and managing their obesity. But obviously, outside of the patients without diabetes, cost is a factor, and I think accessibility still remains a factor. I mean, you guys would probably know better than I would about that, but that seems to be the theme that keeps coming up in our clinics when we recommend something like that. Yeah.
Totally. Hey, thank you so much. I've just realised that we're just over time. And thank you, Dr. Behary, Dr. Wilson, and Nathan and all of our attendees. Please complete the survey that's going to pop up in your web browser. A quality improvement activity, a mini audit, will be sent via email to our participants this evening, and can be completed as a part of this CPD event. And it'll be really great to complete the audit. It's really simple, but it's also, I guess, consolidates what we've learned about today, and it has some excellent links to some more materials that we can use in general practice. We look forward to everyone coming back online soon. Thanks so much again, everyone.